I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and to start this. Thank you. Over to you, ma'am.
Thank you, Navneet. Welcome trainees to the session today. We have the honor to have Dr. Avni Skandan with us today. Ma'am is lead consultant and head of radiology, and she's also the quality chief at Aster MIMS Kottakkal in Kerala. Dr. Avni will take us through an academic feast today in the 1 hour given to her in the form of GU2 spotters. Now, spotters are which come in the exams, in your MD exams or the DNB exams, now have replaced them with OSCEs, but still the OSCEs are based on these spotters. The questions are asked these spotters, the clinical questions. So ma'am is going to take you through about 50 spotters in this time. And so over to you, Dr. Avni. Welcome to the National Board platform.
Thank you so much, ma'am. I'm really privileged to be here. And I hope this session will be useful to you all. And to make the most of this session, like ma'am said, I'll be presenting some spotters. I'll be asking you some lead questions. It will be radiological and clinical based questions. I want you to get as involved as possible because only then you're going to make the maximum use of this session. So I'll start, and please start typing your answers in the chat section. I'll try to keep a tab of the chat also. So I think I'll start off. So first, this is an X-ray. This patient is presented with an acute flank pain. I want you to tell me what is your primary diagnosis. So I think you can start with that. What is the primary diagnosis and what is the associated complication that you're seeing here? Very good. I think there's some lag. I've already started getting answers. Good. Yeah, so it's pretty straightforward. It is emphysematous pyelonephritis. I'm seeing all of you are getting it right. Yes, there's only one person who's told me the complication till now, that's Divakar. There is an abscess. I asked you what is the complication also. So yes, there is emphysematous paleo. You can't talk about a vein thrombosis on an X-ray. Somebody's told a vein thrombosis. You cannot comment on a vein thrombosis on an X-ray. Yes, if you can have in an infective scenario also, you can have, it's rare, but you can have it. But it is something you will pick up either on an ultrasound or on a cross-sectional imaging. X-ray is not something where you will be able to comment on that. So emphysematous pyelonephritis and the fact that there is an abscess is something that you have to comment because you're seeing an air fluid level that's there in the perinephric space. So yes, there's something else in addition to these two findings. I want you to tell me that also. What is the other finding that you're seeing? I got two of the findings. You did tell me it's emphysematous pyelonephritis. You told me it's an abscess formation in the perinephric space. What else? Something related to the same spectrum. Again, a further complication of the entire the same spectrum. Yes, very good. So there is also retropneumoperitoneum. There's a free air in the retroperitoneal space. So you have to make a note. We call it the satisfaction of search. The moment you see something, don't stop at that because there might be something much more than that. There might be something that is related to it. There might be something which is totally apart from it. So don't stop searching the moment you see something. So here it's actually an entire spectrum. You're seeing there's emphysematous pyelonephritis, you're seeing an abscess, you're seeing there's free air in the retroperitoneal space. It's all a total spectrum. So don't stop with this. You have to make a mention of all of these things. Okay. So when you see, how do you classify it? You can, based on the amount of, or the area of involvement, you can say, or else you can say based on which area is involved. So you have it only in the collecting system, that is class 1. Class 1. When you have it in the renal parenchyma, you have it the class 2. When you have it in the pre or pararenal spaces, it's called as the class 3. And if you have it affecting both the kidneys, you have emphysematous pyelonephritis affecting both the kidneys, it is class 4. Or if you have a solitary kidney and that is what is affected, basically meaning, this is a very fulminating disease. So it can, worsen rapidly. So that is why the importance of it. So if you have a solitary kidney and that is affected, that again becomes class 4. Now, You're seeing a lesion, which is very obvious. Nobody needs to search for it. It can have differentials, but I want you to say what is the first thing that comes in your mind when you see this, and what is the typical imaging finding that you will describe here. Very good. So somebody has just told it. I have got just one response till now. Yeah, so no, it's not angiomyolipoma. Yes, most of you have got it right. Most of you are telling it's oncocytoma. We cannot definitively tell it's oncocytoma, but yes, this is how we classically describe it. And this is what we say the spoke wheel appearance. But there's somebody who said angiomyolipoma. Angiomyolipoma is not a possibility. You don't see fat. You can have fat poor angiomyolipomas also, but this is a classical description of an oncocytoma. So when you say this is an oncocytoma, again, somebody said stellate sign, very good. That is the stellate sign. Spoke wheel is when you do the angiogram. That is when you get this kind of an appearance. So can you confidently tell me this is not renal cell carcinoma? That's the second differential. Can you confidently tell me this is not RCC? Yes or no? Can you confidently tell that? No. Very good. So why would you can have a central scar or this kind of an appearance on and in an oncocytoma, you can see the similar kind of an appearance in an RCC also. So why will you see that kind of an appearance in an RCC? You're seeing it in an oncocytoma because you have a central fibrous scar. What is it in the RCC that gives a similar kind of an appearance? Very good. Only histo can tell it. Yes. Okay, somebody picked up a hypodense lesion in the liver. Very good. I actually didn't make a note of it. So very good. That's exactly what you just don't stop it there. I myself haven't seen it. I was concentrating on this. So it's a very good pick. So yes, central necrosis. So you see an RCC having this similar kind of an appearance because there's central necrosis in an RCC. But when it is an oncocytoma, it's a central fibrous scar. And you cannot tell them apart in any way. So it is a focal resection that is done. So it is it is not recommended to do a biopsy because there's an overlap in the type of imaging. I mean, in the pathological findings also between oncocytoma and chromophobe type of RCC. So always a limited resection is preferred. And if you see any features of invasion, then the case is straightforward. You know for sure you're dealing with RCC. You see a thrombus in the vein. You see it going beyond the margins of the, it's infiltrating into the perinephric space, the Girota's fascia. Then you don't have any doubts. You know you're dealing with a malignancy. So next, this is something that was done for, say, the spine. You have seen and instantly you have detected a lesion here. What do you think is the lesion? Okay. Yes, it is an angiomyolipoma. Why are we saying it's an angiomyolipoma? Why are we saying it so confidently? It's an you're just seeing a single lesion, so you wouldn't label it as VHL. This is a T2-weighted. This is a fat suppressed image. You are seeing this lesion completely suppressed on this. When you're seeing something that is completely suppressed with signal on fat suppressed, it means it is fat. So everything around it has suppressed, and even this has suppressed. So this is a fat suppressed sequence, and the fat is what suppressed. So this is an angiomyolipoma. Now, the next thing I want you to tell me is, what do you think? Somebody has said that you should go for a contrast angio. No. What is your next plan of action for this patient? There are a couple of you who are saying it's a contrast angio, but do you really want an angio to be diagnosing? You don't need a biopsy for an AML. Yes, you need an embolization. And when would you ask for embolization for an AML? What is the cutoff criteria for which you suggest embolization? Follow-up is an option. Yeah, 5, 7, no, it's actually 4 centimeters. 5 is acceptable. 4 centimeters is what it is. So here I have not given you the measurements, but you don't really need measurements always. Eyeballing is something that you should get used to also. When you see the kidney, this is like, more than half of the size of a kidney. So definitely it's going to be about 4 centimeters. It's a normal kidney. So this is definitely about 4 centimeters. So this is something that is not going to be kept on follow-up. You are going to recommend them to meet an IR guy, and this person is a good candidate for being taken up for embolization. Not because there's anything wrong. Now, why do we do an embolization for these patients? Why should we suggest an embolization for these patients? Yes, they can develop spontaneous hemorrhage that can be catastrophic. So yes, so there is a propensity for bleed. It is catastrophic. So to prevent that, when we when you have these patients on follow-up and you see that something has gone beyond 4 centimeters, we suggest them to meet an IR guy and go for an embolization. So yes, this is what I said. Okay. Now, this is cross-sectional imaging. This was done for something else entirely, but this is the section in the, right through the center of the kidney. You're seeing 2 structures in the middle of the kidney. What are those structures? And what are you going to do about them? Yes. Most of you have said it's column of Burton. Very good. It's not a dromedary hump. Column of Burton is because it is, how do we say for sure it is column of Burton? Because it is exactly like the cortex. It is even on the normal, on the contrast enhanced, everything, it's going to look exactly like the cortex. And when you look at it on the ultrasound, you will see the vessels will be going through them. It's not going to be displacing them because it is something that is part of the normal kidney. So it is just a normal variant. You don't need a follow-up. Most of you have got it right. Dromedary hump is something that is protruding out of the kidney. This is protruding into the sinus fat. Dromedary hump is something that causes a contour deformity. So that is different. This is different. Both are normal variants. Both are some things we can be mimicking mass lesion, but it is something that we just need to label. So, okay. Now, this is a 13-year-old boy. He is undergoing hemodialysis. So what is the pathology that you're seeing? Polycystic kidney disease, yes. ARPKD is yes. It is not ADPKD. It is ARPKD. Many of you have said ADPKD. When it is ADPKD, it presents late. It comes, it presents when they are adults. When it is recessive is when it starts presenting in the childhood. And somebody said VHL. Why are we thinking of VHL? we are only seeing cysts in the kidneys. We are not seeing it anywhere else. So you're seeing this huge kidneys. It is maintaining its uniform shape. You're having multiple small cysts studded throughout both the kidneys. So yes, that is what you're seeing. And it is presented in a 13-year-old boy. You're seeing it in a 13-year-old boy. So you would have presented much before than that also. So it is an autosomal recessive one. The dominant one would have started presenting or started developing the cyst somewhere towards the middle age or something like that. So this is an ARP kidney. That is something you can say a polycystic kidney. But again, you need to be telling which type. It's an ARP kidney. Now, there is something else that you're seeing here, and I want you to tell me what is it other than leave the kidneys alone. Yes, very good. There are a lot of associated findings you have told me. Aneurysm is a finding that we see in ADPKD. Somebody's told that. Liver fibrosis, yes. Again, berry aneurysm is something that you will see. Cystic hepatic lesions is something that you'll see with ADPKD. We are dealing with ARPKD, that is acute recessive polycystic kidney disease. Okay. So now tell me, what else are you seeing other than the kidneys? Leave the kidneys alone. What other things are you seeing here? Something else. Yes, very good. You are seeing hemocidrosis. And how did you say that? You can have hepatic fibrosis, but you can't be sure by this image that it's hepatic fibrosis. So yes, the liver is black. Is only the liver black? Is there something else that is black here? Dark liver and spleen. Very good. So there's dark liver and spleen. So that means it is, you can have primary, you can have secondary hemochromatosis cirrhosis. So here you are seeing secondary. There's a deposition. Why is this? This patient is on a long-term hemodialysis. So this patient has a propensity for hemochromatosis or hemocirrhosis, deposition disorders. So this is secondary to the treatment that he's undergoing. It's not because of the disease per se. Hepatic fibrosis is something that occurs with ARPKD, but that is not something that causes a signal intensity change of this drastic nature. It might cause fibrotic changes. Most often you can pick it up on either you need to check the you do need to do an elastography, or you need to demonstrate focal fibrotic areas in the liver by MRI. But it is primarily, if this is a diagnosis, this is only telling you the intensity. There is some deposition that has occurred in the liver and spleen. That is because of the hemodialysis that the patient is undergoing. So, okay, this is a 40-year-old patient, and this patient has bone pain. That's the only history I'm giving you. This patient has bone pain. So what is it that you're seeing? What is your diagnosis? Very good. Somebody got it right. I thought I'll have to probe you guys a bit for that. Not multiple myeloma. Yes. Yeah, all of you have got it right. Good. That's not renal stone. I think this patient has stents. So that's not renal stones. Hairy kidney is classically, a lot of you have got it right. It is Winchester, it is hairy kidney, but somebody mentioned lymphoma. Lymphoma doesn't get hairy kidney, and lymphoma classically tends to involve the cortex per se. It doesn't go in the perinephric space. And it is not Langerhans cell histiocytosis. It is non-Langerhans cell histiocytosis. You don't have it. It is a non-LCH type. Okay. So amyloidosis can have this kind of a deposition, yes. And but I gave you a leading question. I told you this patient has bone pain. So if this patient had to undergo an X-ray of, say, the knee, what would you see in this patient? We came to the diagnosis. This is hairy kidney. This patient has a Winchester disease. Now I want to know, what is this patient going to have in his chest X-ray? Cortical sclerosis, it is not multiple lighted lesions. It's not cortical sclerosis. Very good. There is going to be metaphyseal sclerosis. There can be metadiaphyseal sclerosis. That is the classical appearance that you will see in the bones. Cyst, yes, but cyst is something that is going to come in the lungs. Diaphyseal eclasia, no. Diaphyseal eclasia is where you have multiple osteochondromas. You will have cystic lung disease, yes. So, okay, this is the spectrum that you will see. In the kidney, I'm just talking about the most important findings here. So in the kidneys, you see this classical hairy kidney sign. This is what I was describing. You have the metadiaphyseal sclerosis that you will see. In the lungs, you will see the cysts that you all have mentioned. You will get the classical LCH kind of a distribution of cystic changes. And you have this very classical appearance of brain changes. You get this dural accumulations here, and all these accumulations are very classically, they may mimic meningiomas, but they are classically T2-weighted hypointense. There are very few things that are T2-weighted hypointense. So this is something which is very classical, just like the metadiaphyseal sclerosis also. So this is Erdheim-Chester disease. Now, this is a patient who is presented with loin pain. This is a borrowed image from the Radiopedia. Skip this stent. Don't bother about the stent. Talk about the rest of it. What do you think about it? Very good. Okay, I'm getting a lot of varied answers, and I can understand why it is, because it's a very weird looking X-ray actually. Couple of you have got it right, ADPKD. There are many who are saying calcified metastasis, calcified peritoneal metastasis, hydatid cyst, peritoneal cyst. It's all actually acceptable. I wouldn't say you're way far if you give them as your differentials. The reason being it's scattered all over the place. So yes, you're not wrong in thinking that it could be peritoneal metastasis, it could be calcified peritoneal, especially these ones, they look so smudged and it doesn't have any margins. So you wouldn't be wrong in telling them as your differentials. But if you look at these cysts here, they are very well defined. It's a cystic area which is calcified. These cysts are really well defined. Okay. And the next thing, how do you proceed when you look at an X-ray? What do you have to go in a, don't jump at what you see. Go through your systematic. You should have a checklist whenever you see X-ray or you go through any imaging for that matter. Then you wouldn't miss findings. So if you're looking at a chest X-ray, everybody would have different ways of doing it. Somebody will look at the bowel first. Somebody looks at the bones first. Somebody looks at the solid organs first. So in case we start with the solid organs, there's nothing wrong with the bowel pathology. There's no bowel pathology here, no free air. So here I can see the liver contour, and maybe here I can see the lower pole of the spleen. Where is the renal contour here? You can't make out the renal contour. So you know that there's something that's obliterating the renal contour. That is something which is very clear. Renal structures is something in the retroperitoneum. So something that's peritoneal, like if we go in a, correct format, if your mean differential was peritoneal, for most of you, quite a few of you have said peritoneal. So if it was peritoneal metastasis, it does not need to, obscure the renal parenchyma or renal contour, because that is something that is retroperitoneal. So when does it obscure your margins? When it is abutting you. So something that's peritoneal is never going to obscure something that is retroperitoneal, which is not anyways close to it. Okay, so we are not seeing. So now what do we have? We have the renal contour is not seen on both the sides. You have something that is bulging out the abdomen. You can see this bulge. It's just protruding the abdomen. So it's just filling. This whole space is filled up. Okay, and then you're seeing these calcified cysts. You can say they are cysts here. You can't tell for sure here, but you can see these things are cystic structures which are calcified. So that is why this could be, again, I'm telling you, you would not be crucified for saying that you have thinking of calcified peritoneal metastasis. You are not far from the diagnosis. You would not be wrong in giving that as a differential, but ADPKD is something that should come in your mind because of the distribution and the fact that you're not seeing the renal contours and the fact that these are all cystic. They are not looking like, areas of dystrophic calcification within a lesion or something. It is all cystic lesions which have calcified. Okay. And it's okay to make mistake, please. You can think of hydatid, but again, hydatid cysts are not normally going to, you're not going to really see it all over the place. You're not going to see it in the liver, spleen, and then in the peritoneal cavity and everywhere. You can, but it doesn't grow so haphazardly. This is very haphazard. It's there all over the place. If you see a single large cyst, then you can think of it. Multicystic dysplastic kidneys do not tend to grow so big. This classical growth of the kidney, the huge enlarged kidneys, polycystic kidneys, tend to be in a polycystic ADPKD patient. The other polycystic kidney diseases do not tend to have such large kidneys. Okay. And again, there are people apologizing me for getting it wrong. Please don't. It's always good to make mistakes here. You make it here so that you don't make it there in your exam. So it's perfectly all right. Okay, so this is a 10-month-old child with flank swelling. So what do you think of this? Yeah. Again, I'm getting mixed answers. I got lymphoma, I got neuroblastoma, I got Wilms. Most of you are giving neuroblastoma, which is the right answer. So now I want you to see why it's not lymphoma. One thing is the age group. What do we most commonly see in this age group of less than 1 year? We are looking in the young age group, there are very few things which are so commonly seen. Okay, so neuroblastoma is something that should be at the top of your list when you say a child less than 1 year. So what is it that differentiates Wilms and neuroblastoma? What are, yeah, Wilms, excuse me. Clausine is actually in Wilms tumor. So you cannot use it as a point for neuroblastoma. I'm saying this is neuroblastoma. So you cannot use Clausine. Clausine is, what does a Clausine tell you? When you have something that is, you have a lesion which is originating from here, part of the parenchyma is still going to be here. You know, it's the lesion which is growing from here. It starts growing, but part of the parenchyma still stays, you know, around it. That is what forms the Clausine. So anything when it is arising from something, Clausine is giving you a clue that it is arising from that particular organ. So when we are saying Clausine, we are actually pointing towards Wilms tumor. Neuroblastoma is separate. It's going to compress it. It's not going to give you the Clausine. This is not the Clausine. This is compressing it. There's a slight difference in that. Okay, and crossing, midline crossing, very good. Wilms will invade the vessels. Neuroblastoma will encase the vessels. So here we can, this is again an image from Radiopedia, good one. Neuroblastoma is mostly, I mean, here in this context, we are talking about an adrenal lesion. It doesn't have very good margins. Wilms tumor tends to be more well-defined. It can cross the midline. It will encase the vessels, it will not invade them, and it will compress the kidney. This is what it is all going to push into places. But what will Wilms do? Wilms is not going to push in, it is just going to grow into things. So Wilms is going to grow into the renal vessels, it's going to infiltrate into everything that is around it. It is not going to, you know, be very respectful of you and go around you and all that. It is just going to start growing into you. So that's the difference between Wilms and nephroblastoma. This is, sorry, neuroblastoma. This is based on the imaging. And the age-wise, if you see neuroblastoma in less than 1 year, 3 to 4 years, that age group, you tend to see Wilms tumor. Vessel encasement, okay. Pushing anteriorly, crossing, okay, fine. So this is the next case. And this is a 30-year-old patient who was presented with seizures and mental retardation. So what is this patient suffering from? Very good. Most of you have got it right. It is tuberous sclerosis. Somebody said VHL, but it is not VHL. I'll tell you why. So this is tuberous sclerosis, and yes, it is a triad where you have the seizures, mental retardation, and all. And so what do we see in tuberous sclerosis? Again, phacomatosis is something that is not only important for you theoretically, it is something that's going to come into your practical exams also. So even in theory, it's very important to you for you to know the entire spectrum, and it's very important even for your practical point of view. It can come as spotters, it can come in any form. Phacomatosis is something, each one of the phacomatosis should be thorough for you. It is very important from the exam point of view. Okay. And even in the day-to-day practice, if you are, your eyes need to be sharp. If you've seen something, you should be able to put 2 and 2 together. But you don't come across phacomatosis so much in your day-to-day practice as much as you see it in the exam. Exam, it's much more frequent. So yes, you are seeing multiple fat density lesions in both the kidneys. Multiple lesions are seen studying both the kidneys, that is multiple angiomyolipomas. I've given you the history that this patient has seizures, this patient has mental retardation. So that is actually, this is and I think the third part of the spectrum is adenoma sebaceum. So that is the spectrum that you see. And this is the findings in the kidney that we see. So what are the signs that we are seeing? I'm not talking about these. I'm talking about the ones which we are going to pick up in our imaging ones. We are going to look at the brain. Brain is where we look at the most of the findings. You'll see cortical tubers. You can see the subependymal nodules. You can see SEGA, a dreaded complication. Then you can get retinal hematomas. You can get rhabdomyomas, lymphangiomyomatosis, renal angiomyolipomas, which you've seen. These are the commonest things that we are looking for. This is what we see in the tuberous sclerosis. I'm not talking about the other phacomatosis now because I'll be dealing with it later. Now, what do you think of this image? What are the findings here? Or what is this patient, what is the diagnosis of this patient? Just tell me what is the diagnosis. Yes, this is VHL. The previous one, we were seeing multiple angiomyolipomas. That was tuberous sclerosis. Somebody told VHL there. So this is VHL where you're seeing multiple renal cysts, you're seeing pancreatic cysts, and somebody did mention complication as RCC. Okay. Can you mention any complication that you're seeing in this image? Yes, somebody has already mentioned it, but I'll be happy if others also do. That is why we follow these patients, because we expect some changes to occur in this patient. So what is the complication that we are seeing in this particular image itself? Yes. And which side are you seeing it? Which side are we seeing the RCC? It's actually bilateral. That's why some of you are getting it right and some of you are getting it left. It's actually bilateral. You're seeing one on the right, you're seeing one on the left. So there's RCCs developing on both the sides. The cysts have got complicated. So that is something that we have to look out for. So you're seeing multiple pancreatic cysts, you're seeing multiple renal cysts. You are seeing an RCC that has started developing here and you're seeing one on the left also. So it's bilateral. Okay, so this is VHL, and this is again the most important findings that we see: the hemangioblastoma, endolymphatic sac tumor, the spinal hemangioblastoma, retinal hemangioblastomas, the RCCs, renal pancreatic cysts, then pheochromas, the neuroendocrine tumors. These are the commonest things that we come across. And these are things that we have to keep in mind. Like I mentioned, during exams, it is very, very, very important that you have to know the entire spectrum, not only for your theory papers, but for your practical papers also, for your practical exams also. Now, this is a patient who's had recurrent UTI and is getting evaluated for the same. What is the sign that you're seeing here? Drooping lily. Very good. What does a drooping lily sign denote? All of you are getting it right. Good. What does that sign denote? Duplicated system. Okay, very good. So now if it is duplicated system, why are you seeing a drooping lily? There's something else that you have to add to that. You are having upper moiety pressure effect. Okay, good. But still, yes, you are having a dual moiety. You can see this contour is a bit large. You can see the contour here. You are having a dual moiety here, but the upper moiety is obstructed. It is not filling in. So you're seeing only the lower moiety which is filling in here. So it is the one which is like looking like a drooping lily there. Okay, so it's this is how a drooping lily looks. That's how it normally looks. So you have an upper moiety which is non-functional and which is giving this appearance, because this side, if you see this side also filling up, you'll see it beautifully coming and joining here, but that is not happening here. So it's an dual moiety and the upper moiety is obstructed here. Okay. Next is, what is the finding in this image? Oh, somebody was talking about Wegemeyer, but that is a rule. That is about the reflux and the erythrocele thing. In drooping lily, that is not what happens. Putty kidney, very good. Very good. Okay, so you all know it's putty kidney and it occurs in? Okay, some of you have said it's medullary calcinosis. It's not medullary calcinosis. One thing you can compare with the opposite kidney, the kidney on this side has contracted and the calcification that you're seeing is not restricted to the medulla. It's the entire kidney which is calcified. It is like the autosplenectomy that we see. This is a non-functional kidney which has undergone dystrophic calcification. Okay, you can see this kind of large calcification in staghorn calcification and other. I'm not talking about them because I'm going to be talking about those cases later. Now, what is the term used for this pathology and what is the expected complication of this? Very good. I got a couple of answers. That's not calyctasis. Okay, it is Page kidney, yes. So what is, yes, there's a subcapsular collection. Very good. So I got all the terms that I wanted. It's a subcapsular collection, Page kidney, and hypertension. These are the three things I want to hear when I see this. Yes, you will get secondary hypertension. So these are the three things that I wanted to hear from you guys. So if you see a perinephric collection is going to go all around the kidney. So it's going to spread uniformly in the perinephric space. So it's going to, yes, when the pressure keeps increasing, it is going to cause a mass effect on the kidney. It is going to compress the kidney, but that's going to take a lot of time. Okay, because it's going distributed uniformly around the kidney. But what happens when it is going, there's a collection underneath the surface of the capsule. What happens is it starts compressing the kidney, which is, it is under the capsule and it is compressing the kidney. So when this is happening, it is causing mass effect on the kidney. So when this external compression is there, it is causing mass effect on the kidney. It is causing a renal perfusion is getting compensated. And the renin-dependent hypertension ensues in this patient. So this is called the page kidney. The same effect is not going to happen in a perinephric hematoma. It will happen in the long run when this perinephric hematoma becomes big or perinephric collection becomes big. Okay, so now this is a transplant kidney and transplant kidney on day 12. And this is the Doppler findings. So what is the finding you're seeing here and what does it represent? Okay, very good. Very good. Yes. Increased RI is okay. Yes. So somebody said biphasic flow, high RI, but the most important biphasic flow, what we mean is there's a reversal of the diastolic flow. So that is very, very, very important finding for transplant kidney. There is a flow reversal, there's a reversal of the diastolic flow. So this is not the normal waveform. And most of you have given renal vein thrombosis as a diagnosis. That is one of the most important differentials for it. So this is a normal renal waveform. You have a low resistance flow. So yes, you're right in saying it's high resistance. But the most important term that you have to use is there is no, like you said, the biphasic flow. You do not have a biphasic flow in the kidney. So you do not expect the diastole to go below the baseline. But you have in the previous image, you have a diastole which is below the baseline. So there is a reversal of the diastolic flow. And where do you see a reversal of diastolic flow in a transplant kidney? If it is in the perioperative period that is less than 30 days, which our patient is, you can see it in acute tubular necrosis, acute rejection, renal vein thrombosis, some compression on the vessels, either by kinking, hematoma, urinoma, something like that. So the most commonest thing that we will be looking for is the most commonest thing we will be mentioning is a renal vein thrombosis. Okay. Now, this is a patient who has had a history of trauma. What is the finding that you're seeing here? There are many people saying laceration. Where are you seeing the laceration? Perinephric hematoma, subcapsular. Yeah, the correct word is, if you look only at this report, this image and report, you're going to see that there is a collection around the kidney. You know, there's something happening. You might mistake it for a hematoma. This is already an excretory image, but when you go for the delayed images, you will start seeing that the pelvis may say it is leaking out. The excretory contrast is leaking out and it has started pooling in the urinoma. So this is an active leak of the excretory contrast. So there is definitely something in the excretory system. So this just emphasizes the importance of us to have a bit more delayed images when we are suspecting. You see a perinephric hematoma, you see a periureteric hematoma, periureteric perinephric collection, perivesical collection. Make sure you do further delayed images to be able to demonstrate if there's any contrast that is leaking out. Okay, so yes, because I'm running short of time, I'm just skipping a lot of descriptions. This is a patient who has had history of trauma. What is a possible diagnosis? I'm skipping a lot of discussion because I have a lot of slides and I won't be able to cover them. Yes. So it is, yeah, most of you are saying it's a pseudoaneurysm. It is a pseudoaneurysm and not an aneurysm as has been mentioned by a couple of you. It is a pseudoaneurysm. And why is it a pseudoaneurysm? What is the difference between a pseudoaneurysm and an aneurysm? What is the difference? Most important difference? Yes. There is not the complete wall, all the layers are not there in a pseudoaneurysm. Pseudoaneurysm is something that has come iatrogenically or secondary to a trauma. So it is something that has been artificially created. You have gone for a biopsy, a PCNL trauma, something like that. It is causing, there is a defect that occurs because of which a pseudoaneurysm develops. It's not a proper aneurysm. So again, the types of the aneurysms you can read up, and the intervention I'm not talking now. What is this pathology? Very good. So it is FMD, fibromuscular dysplasia. The patient would have presented with. What would be the patient's presentation? Hypertension. Very good. And what would be the age group of this patient? Middle-aged female. Very good. So this is most often seen in middle-aged female, and what classically you can see is a string of beads sign. This is the classical appearance of fibromuscular dysplasia. And one more classical thing that you can see here is you can see that the osteo is preserved. If it was atherosclerosis, it would have occurred in the older age group, and the ostia would have been involved. Inevitably, it's the ostia which gets involved in the atherosclerosis. But when it is FMD, you see that the center part of the renal artery gets involved. The patient tends to be middle-aged and most often females. But this is not the only way it can present. It can also present as a single long stricturous component also. That is also another presentation. Okay, so this is a patient who has painless hematuria. What is the finding? And very good, very good. So it is polyarthritis nodosa. And what is the lab parameter that you're going to do here? What is it that you're going to look for? Something, a single thing. Very good. It is a P anchor that will tell you, give you a diagnosis and tell you how is the disease activity. So it can prognosticate the disease also. Now this case, this patient has presented with chronic flank pain. What is the pathology here? Very good. So you've given me both xanthogranulomatous pyelonephritis, and you're seeing it is called as Pierre-Pause sign. And again, you stage it whether it is there only in the parenchyma into the perirenal fat, or has it gone into the spaces. That is something that it can extend, so we should make a note of that. Now this one, this is an ultrasound image. This is something which we see very often. So what is the pathology seen here? Hyperechoic. What is hyperechoic? You can't say for sure it's medullary sponge kidney. You cannot say it's nephrocalcinosis. It is the medullary or hyperechoic. So don't expect that you classically will see those pyramids which are like, triangle, calcified triangles. That is not how you come across this kind of an image more often actually. So you're seeing the medullary which are hyperechoic. This is medullary nephrocalcinosis. You have multiple differentials for it. So you should be knowing the whole differential list, because it is again something very important from the exam point of view. You cannot tell medullary sponge kidney by seeing this image on ultrasound. You can only say it's medullary nephrocalcinosis. So you can see calcinosis, you can see chronic medullary, or you can see both, or you can see it in the excretory system when it becomes the lithiasis, urolithiasis. So now this patient is presented with right-sided renal colic. What do you think of this patient? Skip this calculus. Strenz-Strauss, very good. So what has this patient undergone? What procedure has this patient undergone? Not PCNL. Lithotripsy, yes. If it was PCNL, they would have just looked the stone and taken it out. So this patient has undergone extracorporeal shockwave lithotripsy. When they break those stones, what happens, it normally just passes over, but sometimes a big stone gets impacted somewhere in the tube. And when it gets impacted, it's blocked the route for everything else. So all the small fragments tend to come and stack up like this. And it's known as, it looks like a stone street, a street of stone. So that's what, I think it's a German term. It is called a Strenz-Strauss. So most often you don't need to do anything. It will just pass off on its own. When it doesn't is the only time you need to intervene for it. So this is something which is very common, right? Ureteric colic. I want you to tell me what is the additional finding you're going to mention in this. I'll tell you the finding. There's a calculus here, but I want you to tell me some other point that you should be mentioning in this too. In this study, whatever. You can't say it's reflux, fat stranding. Yeah, but you don't see a lot of fat stranding here. Mural thickening, yes. So we do see stone, something very common. It should not be coming as a spotter for you. But the only reason I mentioned is because I wanted you to make sure that you always mention if you see stone, you see ureteric wall thickening. One thing, when you see the soft tissue rim sign, it tells you whether it's a phlebolith or it's a stone per se. But the other importance is it can suggest the fact that it's an impacted calculus and there would be intervention needed. So a note of that will be helpful for the urologist. So that's a soft tissue rim sign. So what do you think of this? Very good. Horseshoe kidney, it's a the commonest renal anomaly that you're seeing, anatomical abnormality that you see. And here you can make out very well that it is fused in the lower pole. So again, I'm not talking about that. Now this is a case of, I will lead you halfway through. There's a stone sitting down here. Okay, so because it's difficult to pick up, there's a stone sitting in the distal ureter or the VUJ, and this is the appearance in the coronal. This patient is presented with fever and sepsis. Yes, very good. So I have started getting answers, but very few. Yes. So what is it that has happened? Calculus is there. There's an obstructed system and a secondary infection has occurred, because of which you are seeing there is stranding here. There's wall thickening. There is periureteric and peripelvic calycial stranding. You're seeing significant stranding, and even within that, you're seeing enhancement. So this is basically a secondary infection that has occurred. So you can get secondary infection. The system may rupture, extravasation might occur, a lot of things. Further, in the long run, it might go into an obstructed system, which is having a renal loss. So this is a patient. This was, this is a patient who had presented with, no, sorry, skip this, the history I've got mixed up. This is a patient who had this, was getting evaluated for something, was getting evaluated for hypertension. I don't have time, so I'll just rush through. Was getting evaluated for hypertension, and this is the findings on ultrasound, MRI. Yes, very good. That's what I wanted. Pheochromocytoma, and this is classically known as the light bulb sign. So this is something, it is not fairly pathognomic for it, but yes, it is something that is going to stay for pheochromocytoma. So this is the 10% rules, and again, the spectrum of the imaging you'll have to check up. Now, in this renal carcinoma, what is the nephrometric score? It is very obvious that this is the renal cell carcinoma. I want you to tell me what is the nephrometric score. You can see I've given you the pointers are also there. This is the measurement. It's around 8.5 centimeters. This is the coronal images showing you the relation with the polar lines. Its relation to the excretory system. It's all there here. Okay, I'll just jump to the next slides so that we can rush through. So for those who do not know the nephrometric score, one thing is the size criteria, then how much part of it is endophytic, exophytic. This is the exophytic, and as it grows to the endophytic, the score increases. It is 1, 2, and 3 points. Then how far it is away from the excretory system. So whether it is 7.4 to 7 less than 4 mm, that is another point thing that gives you the points. Then you determine from the polar lines, you say whether it is anterior, posterior, or when you cannot comment whether it is anterior, posterior. And the last point here is going to be the polar lines, the relation to the polar lines, either it is above or it is crossing them, or it is somewhere between them. So in our particular case, when you look at our particular case, this is our case, you're seeing that the size is 8.6 centimeters, which is more than 7 centimeters. So it is 3 points. This is ours. You have less than 50 more. You can see a large part is exophytic, but more part of it is endophytic. So when you have less than 50%, which is endophytic, it is 2 points. Or less than 50%, which is exophytic, it is 2 points. Then it is very close to the excretory system. It is abutting the excretory system. So again, when it is very close to the excretory system, it becomes 3 points. You cannot say it's anterior or posterior because it is extending all across. So it becomes X, means you cannot say it is A or P, it becomes X. And in the polar lines, if you look, it's there at the superior pole, it's going below the polar lines, and it's going to be between the polar lines. So again, it becomes 3 points. So this total becomes 11 points, 11x. 11x becomes the severe stage. There are 3 categorizations. Read up nephrometric score for your reporting system, for your reporting and for your exam point of view, both. Now, what is the staging of this RCC? Okay, so it is 3 because when it is 1, it is less than 7, more than 7. And the next one is when it is going to the perinephric, but in the girotas, we have a tumor thrombus in the vein. So here we can see that our lesion, it is there, it's a huge lesion, but it is growing into the tumor thrombus is going into the vein. So this is the 3. Okay. Now, in this particular, what is your diagnosis by seeing this one particular image? Again, I told you satisfaction of search. You know it's GOT, so you're limiting yourself to GOT. Don't limit yourself that way. Always look all around. Be sure you're seeing everything and then try to give your probable diagnosis. Look all around the film and then try to give your diagnosis. Don't stop with something. Yes. So when I said that, you looked at the rib mets. So when you see rib mets, what does your differential changes or not? If from an abscess, it automatically moves into the possibility that this is going to be a malignancy, which has left you with a metastatic lesion. Okay. So this is lung CA with metastatic lesions. So satisfaction of search avoided. What is the spot diagnosis? Adenomyosis. Yes. So again, I'm not describing, it's very classical one. The zone of the junctional zone has expanded, the myometral hyperintensities, I'm not explaining it. So now, what is this? This is an asymptomatic patient who was found to have something on the ultrasound, was being evaluated for that. There was an adrenal lesion which was found on ultrasound, and this patient is being evaluated for that. Yes. In phase, out phase, chemical shift, adenoma. Yes, very good. It's not a gradient image, it's an in phase and out phase image. So when you're seeing it's an in phase and out phase, you're seeing this is the adrenal lesion. This is the adrenal lesion. So when you're seeing this has dropped signal here, means there's a chemical shift artifact which has occurred here. This is suggesting that there is fat within it. So this is an adenoma, adrenal adenoma, if you're seeing this drop in the signal. So that is favoring. So again, I'm not describing it further. This is an asymptomatic patient. There is something, this CT was taken for some other reason. And this patient, you incidentally found something here. So what is it? It's something small, so you better be careful. Yeah, adenoma, it's a myelolipoma. It's something so small. And this is how a myelolipoma looks. Myelolipoma is almost entirely fat. Adenoma can be lipid rich, can be lipid poor. So you might have to dig in and look for the density. You don't see it like this. Myelolipoma is something where you have striking fat in it, but adenoma is somewhere you don't have, you have a lipid rich adenoma, but you still don't get the striking kind of an appearance. Okay. So this is the patient who was presented with severe colicky left-sided pain. And this patient had a history of calculus. What is your diagnosis? I already mentioned this. Yeah. So this is because when the calculus and there's a ureteric rupture which has occurred, a urinoma has formed. So that is one of the, that's a spontaneous rupture that has occurred. When it is occurred because of an iatrogenic or a traumatic thing, the pathology is different. So, okay, this is a 10-year-old child with difficulty in maturation. What is the classical description and what is your diagnosis here? You're not too wrong. Somebody said pelvic lipomatosis. You're not too wrong. This is the classical pine cone or urinary bladder, and yes, it is seen in neurogenic bladder also. But the thing is, when you see this kind of bladder and pelvic lipomatosis, it doesn't tend to occur in children. I said it was a child. So we should put all the history that we get, put it all together and try to give a diagnosis. So then you prioritize. You might have a list of diagnoses which is there. You might have a lot of features which are there. So you have to prioritize based on the history, the imaging pattern, and everything that you see around it. Like I said, the previous one could be an abscess. Very well, it could be an abscess. But the moment you're seeing a reblation, put your malignancy with METSS first. Doesn't mean that this is not an abscess and this is not an independent pathology. But based on your history, based on your entire spectrum, make sure you change your prioritization of the list. Okay. Yeah. So this is a patient who had an RTA and so an X-ray. What is the finding seen here? There's another history important. 25-year-old Middle East based patient who had a motor vehicle accident. Yes, schistosomiasis. Always don't look for something that is we are expecting. Just because it's an RTA doesn't mean there has to be a fracture, and you cannot diagnose a bladder rupture on a non-contrast enhanced. If you have not instilled a contrast in the bladder, you cannot talk about bladder rupture. So don't say bladder rupture on a plain X-ray. You are seeing calcification along the bladder wall and along the distal ureter. So this is the case, and the fact that this patient is in Middle East where schistosomiasis is very prominent. So you have to keep schistosomiasis as your differential. Now, this is a patient who had an alleged assault while intoxicated. This is the CT imaging. What do you think of it? Very good. Intraperitoneal rupture. Why you're seeing it into the perivesical space, into the intraperitoneal space? Yes. Again, the types of the bladder rupture: extraperitoneal, retroperitoneal, the interstitial UV injury. I'm not talking about it. Recurrent UTIs. What are the three findings that you're seeing here? Yeah, duplicated system can have, yeah, everybody said duplicated system, everybody said there's a uretrocele, but also you can also say that it's a bifid ureter. It's not a completely duplicated system. So it's a bifid ureter and duplicated system which is joined and given then there's a uretrocele. Yes. So this patient has a right flank pain. What is the finding? What is this case? Retrocable ureter, very good. So, okay, so retrocable ureter, again, you can have type 1, type 2, whether it is high or low. So again, not going further into it. Now, this patient has been having recurrent UTIs. It's a zoomed in image. So if it's been zoomed in, it's been zoomed in for a reason. It's something very subtle. It's not an ectopic kidney. It's been zoomed in a lot, so it's looking like that. The kidneys are in the place. I'm not sure if it's projecting too well on your screens. It's actually, you can see these small things here. Here, small defects you're seeing all around the places. Yes, this is ureteritis cystica, which is a submucosal small 3 to 5 mm structures that you'll see. Now, this is a child who is irritable, has a poor urine stream, has bilateral undescended testis. Look at the entire picture. You're seeing this obstruction, okay, because you're seeing a dilated system. Look at the entire picture. Yes, prune belly. Where is the anterior abdominal wall fat? Muscles. You do not see the muscles per se here. So there's a prone belly, and you have to have the entire spectrum. I mentioned there is undescended testis already. You saw there's no anterior abdominal wall, muscles are not well developed, and you saw that there is a dilatation of the system. So that is the spectrum of prone belly syndrome. So always don't limit with yourself with a thing that is very obvious and striking. This is very striking, yes, but look at the whole picture. Make sure you see the striking thing. Make sure you pass your eye around everything else also. Now, this is a patient who has recurrent UTIs. It's a 3D Recon image, a very beautiful image actually. It is not an MCU. And it's not a beaded ureter. Yes, it is outpouching. It's not that the ureter is constricted. The ureter is going very nicely. You cannot say it is reflux because it is not an MCU for you to say that. This is an excretory cystis image which has been reconstructed. So these are small outpouching. So they are pseudo-diverticulae from the ureter. Okay. Now, this is a patient who has history of seizures. What do you think of this? Very good. So that was a tuberous sclerosis, and you have AML, we have discussed it, and one of them is rupture. Now, this is a patient who is a diabetic woman who is having abdominal pain. I don't know what I have written there. So it's basically abdominal pain. That's what I meant. Somebody gave me half an answer. Yes, it's emphysematous cystitis. There's no emphysematous pyelonephritis here. The kidneys are okay. The system is okay. It's only air in the bladder. So I think if I would not have given the diabetic woman, you would have still been searching a bit. I'm not sure. Okay, anyways, that is a lead question. Diabetics is where you see it most often, and otherwise immunosuppressed patients. So this patient, young patient who had a sudden swelling and pain in the penis post sexual activity. This is ultrasound images. Yes, yes. But something more than that. Is it just, yes, penile fracture, but there is also urethral injury. You have to make a mention of that. We are done in RGU because of that. So you are able to see this breach here. That is very well seen. You're seeing the hematoma around it. But when you do give a contrast, you see that it is leaking out. So it's a penile fracture, but you have to mention that it's a urethral injury is there. That is when your answer gets complete. Okay. So, okay. This is a young patient with recurrent left flank pain, so was getting evaluated and had this as part of that. So tell me, what do you think of this? All of you are saying cross-fused ectopia. Yeah, cross-ectopia. Again, look at the entire picture. Make sure you look at the entire picture. Is that the only thing you're seeing there? Okay, somebody said scoliosis. Why scoliosis? Yes, there's a vertebral anomaly. So we already say now Bacterial is there. So it's an association that we expect. And Bacterial is, if it's not that when you had it in as a child and it's going to disappear when you're adults. So what Bacterial exists when you are a child is going to exist when you are an adult also. So you don't look for Bacterial only in children. You look at it even when you have an adult patient. So here, but the thing is, it's not a cross-fused renal ectopia. It's a cross-unfused renal ectopia because you can see the fat throughout. Maybe if you'll be more confident when you zip through the images. This is a static one, so it's more difficult to say, but you can see the fat throughout. So it is crossed, yes, but it is not fused. And you are seeing a vertebral anomaly, so you have to make sure you mention about that also. Now, this is a patient who has recurrent left flank pain. It's an obstructed system. This was a percutaneous study, which was done. Calliectasis, okay. Is it only calliectasis? Is there anything else? It's not a PUG obstruction. You can see the ureter. Okay. Can somebody tell me a single diagnosis for this? What is a club-shaped calyx? Where do you see a club-shaped calyx? Yes, it's TB. You see a club-shaped calyx because here it's got the entire thing is got destroyed and it's filling and it's all communicating with each other, the infundibulum and the calyx and everything. So it is giving the appearance of this club-shaped calyx. It's all filled in and they're all forming a large club-shaped thing. At the same time, when you come here, the ureter is dilated and then it abruptly narrows because there's a stricture there. So you have this kind of appearance with tuberculosis where you get this multiple strictures here and there. You get these cavities that are formed and when the contrast is pooling here and there. So here you are seeing this renal papillary necrosis. When it is shed through, this cavity has filled up with contrast. So this whole thing has joined together. That is what is giving the appearance of a club-shaped calyx. Okay. Now, what is the diagnosis here? Okay. Very good. And what will be your differential? It's a retroperitoneal fibrosis. Very good. What will be your differential, top differential for this? Lymphoma. And how are you going to differentiate it from lymphoma? You don't always need a contrast to be able to say, I mean, yes, you will need, but you don't need a contrast to be differentiating it from lymphoma. Lymphoma is where the aorta gets lifted up and retroperitoneal fibrosis, plasters the aorta around. It just, and yes, medialization of ureters, whereas lymphoma, kind of displaces it outwards. So, okay. Now, this is a patient, a child who has been having recurrent UTIs. So this is the ultrasound images. This is the right kidney, this is the left kidney, this is the urinary bladder, and this is the MCU image. Yes, very good. PUV. So is that the only thing that you're going to say? Is there something else you should be saying in this? I said always make sure you tell talk about everything. Infection 2, and you're seeing obstructed system. So you have a PUB, you are seeing obstructed systems, you are seeing there's debris in the left kidney, you are seeing debris in the kidney, in the bladder. MCU is demonstrating that there's a dilated posterior wall. So what is the entire spectrum? There's PUV, there's obstructed system, and secondary infection in the left kidney and the cystitis. Okay. Now, this is a patient with chronic lower abdominal pain, T2-weighted image, T1 fat sat image. Tell me what all are the things that you're seeing. Okay, I got 1, 2. There's something more. There's one more thing. Somebody told me a fibroid, somebody told me for endometrioma. There's one more thing that I want to hear. Yes, there are 3 things you're seeing here. You're seeing this fibroid, T2 hypointense, something that's fibrous. So this is a fibroid. So it doesn't matter even what it does because it's a fibroid. And this is hyperintense on T2. It is suppressed on T1, or not suppressed. It is hypointense on T1. So T2 hyperintense, T1 hypointense is what? Fluid. So this is a simple cyst. This is T2 hypointense, but it is not really showing the shading, but it is one mixed intensity thing here, and it is hyperintense on T1. So this is the endometrioma. So you're seeing a fibroid here, you're seeing a simple cyst here, and you're seeing an endometrioma. So you're seeing 3 things in the same image. Make sure you always tell all the 3 things. Now, this is a large lesion that you're seeing in the abdomen. Abdominal distension was the patient's complaint. What would you, I just want to hear one type of, okay, tell me what do you think of this? Okay, I'll lead you. It's yes, it's a ovarian lesion. It's a mucinous cystadenoma. Yes, very good. Again, I would like to take it further. Okay, I'm getting a lot of different opinions regarding this. So how would you describe this? This is a large abdominal. Okay, you cannot say pelvic here, but I'm telling you it's a large abdominopelvic cyst here, which is multiseptated, which you are able to see here. It's multiseptated. It is large. It is T2 hyperintense. It is T1 hypointense, but it has T1 hyperintense areas. So the moment you've seen T1 hyperintense areas, the chances of it being mucinous is very high rather than serous. So the chances of this being mucinous is very high. But at the same time, you're seeing there's a solid component sitting here. I'm not sure if everybody made note. I've not given you a contrast image to talk about it, but the chances that this enhances is very high. There's a solid component. So the chances of this appearing mucinous cystadenocarcinoma is very high. Okay. Sorry. Yeah. So now this is a patient, this is an ovarian lesion. Again, for this cross-sectional imaging, it's very difficult to tell in a single image. I'm sorry. This is an ovarian lesion. Yes, very good. So I'm getting the complete answer. It's a pleural effusion is there. So it's a fibroma with Meek syndrome. Yes, very good. So one thing which is very important, if you see now diffusion is very important these days, we say there's a lot of role of importance of diffusion in pelvic MRI, in ovarian or pelvic masses. So if you see a lesion is T2 weighted hypointense, and if you see it is hypointense on diffusion also, it is inevitably going to be benign. That is how the description is. Black on T2, black on diffusion, it is benign. So it can be fibroma, it can be a Brenner's tumor, it can be a lot many things with fibrous component or a thecoma, but it's something which is benign. Okay. Now, this is a patient with infertility. HSG was done. So what do you think of this? Somebody said septate. Why septate? Yes, it is uterine ridulifis. Why bicornuate? Again, look at it. You are seeing, I would accept it if it was still here, if you were thinking of bicornuate, because yes, you're seeing 2 corners here, but it is dipping down right till the bottom. So it's not just the uterus which is separate, it is going right till the bottom. The cervix is also separate. So you're seeing this is right in the vagina. So from the cervix, everything upwards is separate. So it's entirely 2 different canals. So it is uterine ridulifis. Okay, and you can read up. I won't take time now. This is a patient who was getting evaluated for pelvic mass. This is the uterus. And you're seeing 2 lesions on either side. Mets. Okay. What Mets? Krukenberg. Very good. Solid bilateral ovarian tumors, Krukenberg. Where do you think it will come from? If you see you're thinking of Krukenberg, what is your primary? You will look for stomach. Stomach, okay. Where else? Stomach is the most common. You can get it from Stomach, colon, breast, lung, or the opposite would be here. Now, this is a patient who has had postmenopausal bleeding. Spot case, CA cervix. Very good. So what is that one single, if you don't see such a big line, such a big mass lesion sitting here also, what is it one single thing that you're going to look at an MRI that is going to tell you that whether there is a CA cervix? What is lost in a CA cervix? So what is the thing that you look for in a cervical MRI? No. Parametrium and all goes when you are looking for its infiltration into the parametrium. Yeah, T2 hypointense signal of the endocervical line, the mucosa here, you should look for that line. So you might have something that is very restricted to that particular region, but if that T2 hypointensity is lost, that is possibly the earliest sign. You may not always see it like a mass lesion, but you have to specifically look for the T2 hypointense signal. Now, this is a patient who is a young female with amenorrhea. What are you thinking of? Very good. I got hematometra, I got hematocolpos, I got imperforate hyphen. You cannot say hematosalpinx in this particular one because this is a SAG image. In maybe in the coronal, yes. So, okay, you're seeing that the bladder is displaced here, right from the vagina, cervix, uterus, everything is dilated. It is distended with something which is T1 hypointense. It is abruptly stopped here. So, this was a hematometrocolpos and this is an imperforate hymen. So that is why it is all collected. Okay. Now, this is my last case. This patient was again being evaluated for infertility. It is an HSG mate. So what is your diagnosis? Very good. So what are the other things that you can see as filling defects in an HSG? It can be a polyp. Yes, I won't deny it cannot be a polyp. But polyps tend to be more oval. They tend to be fibroids, polyps are the other differentials that you will see. Air can be because of the procedure, but again, air tends to automatically take a globular shape. Polyps and fibroid also tend to have an oval to globular morphology. This kind of, a stretched out appearance, it is elongated. That kind of an appearance occurs when there is synechiae, there's fibrous strands within the uterine canal. So that is an Asherman syndrome. Okay. So that ends my thing. So if we know what we are looking for, it is very obvious. Otherwise, it will be sitting right in front of our eyes and we wouldn't be able to pick it up. So that ends my thing and I hope it was useful. I know I had to rush through in the last. I'm really sorry about that. Anjali ma'am, I'm done with my cases.
Thank you, Dr. Avni. That was really a feast and
thank you, ma'am.
You showed the entire spectrum and you explained the things very well. And I'm glad to see that the residents also participated and we did get a few good answers. So I'm quite happy to see that as well. Thank you, Dr. Avni, very much.
Thank
and
you,
we hope to have you back on this platform soon
Definitely,
enough. It was really a feast. Thank you.
Thank you, ma'am. Thank you.
So you can write. Yeah. Let me see if there are any questions.
Repeat for question 20 and question 34. So I'll take it up again. Is it okay?
Yes, ma'am. Just these two because then we are.
I know I've overshot my time. I just looked at the time in the middle and I realized I was very.
That's fine.
1 second.
That's absolutely fine. It was a very enjoyable session and good for the students as well.
I just need to figure out where my. I'm sorry, I'm not able to figure out where my slides are. 20 and 34, isn't it? 34. 34 is which one? 36. 34 was the retrocaval ureter. So, okay. So this was the retrocaval ureter. I don't know if it's seen. Is it seen? My screen?
Yes. Yes, ma'am.
Yeah, so this is the retrocaval ureter, and that is when it is, it's the reverse J. We describe it as the reverse J. So I did not get time to describe it. So what really happens is ureters normally go parallel to the the large vessels, the aorta and the IVC and all. So what happens in the retrocaval ureter? It goes behind the IVC. So it gets kinked at that point. So you tend to have a dilated system proximal to it. So you can have a type 1 where you are having it. This is what we normally come across, the type 1 where you have it at the L3 level. But type 2 is where you see it at the renal pelvis. I haven't seen one on myself, so I'm not very sure about this. I haven't seen a type 2 yet, but that is the second type that you see. So I do not know what exactly was a doubt in that, but that's the retrocaval ureter. Going to the case 20 is... yeah, case 20 is the, I hope my screen is still seen. This is medullary nephrocalcinosis. What we normally assume is, or what we classically see is that you see the medullae, which you see these hypoechoic things and they have turned hyperechoic, but those triangular hyperechoic structures are not what you always come across. That is very classical. This is how we come across most often during our regular practice. And this is where you start seeing the, the medullae are turning hyperechoic. This is the earliest way where you're going to start picking up the medullary nephrocalcinosis. So again, you are not going to say that it's, a lot of you said that it was medullary sponge kidney. You're not going to say it's medullary sponge kidney by seeing this. You're going to say it's medullary nephrocalcinosis. And when it goes on to your further, diagnosis or further discussion, that is when you're going to list out your differentials. There's a lot of differentials, and you will have to, maybe based on their lead questions or the history that they have given, you have to narrow down your diagnosis based on that. But you cannot say it's a medullary sponge kidney based on that image alone. Okay.
Thank you, Dr. Avni.
Okay, thank you.
So much.
Okay, ma'am. Thank you, ma'am.
Thank you very much, Dr.
Thank you,
Avni, for the presentation, and thank you very much, Dr. Anjali Prakash, for joining us. And thank you, trainees.
Thank you.